Okay, this is the chapter on diseases of the respiratory system. So we'll talk about the structure and function of the respiratory system and its defenses. The respiratory system is another one of these body systems that's open to the outside world at the nasal and the oral cavity. The upper respiratory tract runs from the mouth all the way down to the larynx, and the lower respiratory tract runs from the trach all the way down into the lungs. And you can see here that the two functional divisions of the respiratory tract work together. The major task is to load oxygen into the blood and remove carbon dioxide from it. It also has a role in maintaining the body's pH. The conducting division runs from the nasal cavity all the way down to the terminal bronchioles, and that's basically a pipe to get the air down into the respiratory division of the respiratory system, which is in the lungs, and runs from the respiratory bronchioles all the way to the alveoli, and that's where gas exchange actually happens. Now you can see here that in the upper respiratory we have a lot of defenses against infection. We have pseudostratified ciliated columnar epithelia that produces a sticky mucus, and the mucociliary escalator is able to pump that pathogen and particulate-laden mucus up into the oral cavity, at which point you can either spit it out or swallow it. Either way, it doesn't end up down in the delicate tissue of the lungs, where it would produce irritation, inflammation, and scarring. If you swallow it, it's going to go into the acid bath of the stomach, and likely most of the pathogens at that point will be killed. Remember that the cilia move using the energy from ATP. This is one of the reasons why in people that smoke, the particulate and pathogen-laden mucus gets down into the lungs, because the carbon monoxide in the cigarette smoke actually paralyzes the cilia. The nasal hair also traps particles, as does the mucus that's produced in the nasal cavity. And of course, we've already talked about the mucociliary escalator. In addition, we have complement and antimicrobial peptides, chemocytokines, and macrophages all standing guard, as well as IgA. Remember, that's the dimeric antibody that's produced once we've encountered a particular pathogen present in the bulk of our secretions. Our saliva, our tears, our sweat, our mucus secretions all contain IgA. We'll talk about the normal biota that are here. We see strep, we see Haemophilus influenzae, strep pneumoniae, Neisseria meningitidis, all of which can cause serious disease, but they're kept in check normally by the defenses of the respiratory tract. The lung microbiome differs in patients that have COPD, asthma, and CF. Chronic obstructive pulmonary disease is a condition where the wind speed is cut down as a result of secretions or scar tissue in the conducting division. And in asthma, what we have is a reversible obstructive condition where the encounter of a trigger causes inflammation, and that also blocks wind speed. Both of these result in problems with gas trapping. We get carbon dioxide down into the lungs, and that's going to affect the microenvironment in the lungs. The secretions can also serve as a medium in which bacteria can grow. In cystic fibrosis, for instance, one of the complicating factors is the fact that bacteria grow in the salty secretions, and as they die, they release DNA, and that thickens the secretions and makes them more difficult to clear, and this also irritates, inflames, and scars the lungs. Candida can also colonize the mucosa, and we should note that smokers and non-smokers have different biota. Again, the components of cigarette smoke act as a selective pressure for people that engage in that habit, and as a result, different organisms are going to grow there. Normal biota perform the function of microbial antagonism. They reduce the chances that pathogens get a foothold by competing for space and for resources. Lactobacillus suppresses corynebacterium in the sinuses, as one example. And here you can see the defenses in the upper and the lower respiratory. So we're going to talk about pharyngitis and the virulence factors associated with it, and talk about features of infectious diseases of the respiratory tract, such as rhinitis, otitis media, and diphtheria, and identify 2 bacteria that can cause a particularly dangerous form of pharyngitis. So what is pharyngitis? It's what's colloquially known as a sore throat. We see pain and inflammation in the swollen mucosa and swollen tonsils. The breath usually takes on a distinctive foul odor, and you get white packets of tissue on the walls of the throat, often an indicator of strep infection. Sore throats caused by bacteria are painful and more likely to be accompanied by fever, headache, and nausea. Now, that's what a typical sore throat looks like. Those white areas are extremely painful. Even in a viral sore throat, we have the risk of secondary infection, and this is one of the reasons why sometimes doctors will prescribe an antibiotic even if the causative agent for your particular sore throat is a viral one. There's a lot of nerve endings back there, and it makes it difficult to swallow. There are throat sprays that can be used to treat the pain. A lot of them contain phenol, which is good as a numbing agent, but can also cause indigestion. One way of dealing with this, in addition to taking the appropriate course of antibiotics, is to gargle with salt water, and that produces an osmotic shock that the bacteria don't like, and that can shorten the duration of the sore throat. A lot of this is usually accompanied by postnasal drip, where the sinuses can drain into the back of the throat, and the bacteria and the drainage that accompanies them is extremely irritating. And so one technique is to use lavage, where you take a pan of salt water, warm salt water, and you inhale that salt water through your nose and let it hit the back of your throat and then spit it out. And that does the same thing for the nasal cavity and the sinuses that gargling with salt water does for the throat. So this is a look at pharyngitis. And here's a rundown of the causative agents and the treatments. The common cold is generally a viral infection from rhinovirus. Rhino just means related to the nose. There are other types of viruses that can produce the common cold, adeno and coronavirus. Respiratory syncytial gets its name from the fact that tissues infected with it form syncytia, which are multinucleate cells, and that's an abnormal condition for most tissues, with the exception of osteoclast and skeletal muscle. Transmission is through droplet contact or indirect contact. This is why you want to cover your nose when you sneeze. The droplets can hang in the air for 15 minutes, and this is why in the wintertime we get colds more often, because we're more likely to walk through a cloud of droplets and as a result expose ourselves because we're inside more. Symptoms include sneezing and a scratchy throat, a runny nose, and in children it can be accompanied by fever. There's about 200 viruses that cause this. Is there a treatment? Well, there's not an antibiotic treatment, but there is zinc, which has been shown to shorten the duration of the common cold. There are zinc swabs that you can use. There are zinc lozenges, and it interferes with the ability of the virus to attach and infect. But you have to start the zinc treatment early. Um, as soon as you feel like you're getting a sore throat, that's when you hit with the lozenges or with the nasal swabs in order to reduce the likelihood that you're actually going to get the cold. After that point, you just deal with the symptoms. Sinusitis is just an inflammation of the sinuses, and it can be viral or bacterial. It can also be fungal, and it can also be a result of an allergic response. We use broad-spec antibiotics if it's bacterial, and antifungals or surgery for a fungal infection. And again, you can see the rundown here. One of the things we have to appreciate about the respiratory system is that it is connected to the sense of hearing, right? There is a tube called the eustachian tube that connects the throat to the middle ear. And bacteria in the throat can climb up the eustachian tube and populate the middle ear and cause irritation, inflammation, distension of the drum, and extreme pain. This is one of the reasons why if you have a cold or a sore throat, you don't want to blow your nose, because that creates a positive pressure that forces the material up into the eustachian tube and into the middle ear, where infection can be set up. This can be a causative agent, virus or bacteria. Prevention, Prevnar, and Hib. Ultimately, we can deal with this via myristogomy tubes, which are a plastic tube with a collar and a sleeve that's inserted into the drum to equalize pressure on the drum and relieve the pain. It also produces a more aerobic environment in the middle ear that a lot of the bacteria don't like to grow in. The tubes normally are ejected as we age. The eustachian tube becomes more coiled, and it gets more difficult for bacteria to get up into the middle ear. Kids get this a lot because their eustachian tubes are very short and very straight. The myristogomy tubes, once they're ejected, the hole covers up with scar tissue, and then the doctor will remove them with a set of forceps and the use of an otoscope. In the old days, the way that the ear infection was treated was to lance the drum. So you can see here the route of infection in yellow. You would get a distended drum, and the pain would be unbearable, and you'd go to the doctor, and he would take a long needle guided by an otoscope and punch a hole through the drum, and that would allow the suppurative exudate to seep through the hole in the drum and out the ear, and at that point the pain would vanish. And then the drum would heal over, albeit with scar tissue, and that's usually the end of the episode. Now, an important point here is that today we like to use massive doses of antibiotics in an effort to try and treat the infection. Frequently, though, by the time we engage in that treatment modality, the infection is so advanced that the drum ruptures regardless. And when the drum ruptures from the inside out, it tears. And when the drum tears, that scars it more. And a scarred eardrum is a very poor tool for hearing. Your hearing acuity declines dramatically when your eardrum has a lot of scar tissue on it. So a lot of times kids with repeated ear infections and ruptured drums will pass those hearing tests that they have at school, where they just listen for tones, but they'll have trouble distinguishing words. Language gets lost on them because your hearing resolution declines. And so the fix for that can be, in the long term, perhaps a hearing aid. There's nothing that's going to get rid of the scar tissue, unfortunately. That's going to remain, and that's going to have an impact on your hearing for the rest of your life. You worry about these infections coming not only from the throat, but also through the mastoid sinus, because there are lymphatic tissues near your adenoids, for instance, are close by. And if they get populated with pathogens and lose the battle for fighting the infection can spread through the mastoid sinus and into the eustachian tube and ultimately into the middle ear. Those are the bad actors. Okay. Our next topic is diphtheria. It's caused by Corynebacterium diphtheria, and the bad actor in the Corynebacterium is diphtheria toxin. It's a non-spore-forming gram-positive club-shaped bacteria spread by droplet contact and fomites. Dip toxin is actually from a lysogen in the diphtheria, a bacteriophage, and the diagnosis is gray to black colonies on tellurite media. We prevent it with toxoid vaccine. So the way to get around this is to already be immunized against it. The antitoxin, along with penicillin and erythromycin, is generally the recommended mode of treatment. You can see here the virulence factors and the treatment. What you want to note about the diphtheria toxin is that it is a translational inhibitor. Okay, through ADP ribosylation, it kills translation, which means protein synthesis stops, and that's what ultimately kills the cell. We'll talk about influenza and talk about antigenic drift and antigenic shift, and talk about the important features of other infectious diseases such as pertussis and RSV. So here's a look at influenza.
So if you're watching this video, I'm pretty sure that at some point in your life or in the lives of someone you know, they've had the flu. Almost everybody is pretty familiar with how awful it feels to get sick with the flu. And when people talk about the flu, they kind of talk about it in two different ways, and we're gonna get into both of those ways right now. So sometimes they'll talk about the illness or the symptoms they had when they had the flu, and other times they'll talk about the virus, the actual virus that causes the flu. So I'm going to actually break it down the same way. We're going to talk first about the illness, and then we're going to get into the virus. I'm going to draw a nice little line down the middle so that we don't get lost in this conversation. So I can't help it, but anytime I hear that someone has the flu, I immediately get into this mode where I have a bunch of questions for them, and I really just want to kind of convince myself that when they say they have the flu, they really have the flu and they don't have something else. So the questions that pop up in my head, the first one is usually, is it abrupt, or did it kind of start abruptly? I'm going to just write that. Was it abrupt? And I might say, do you remember feeling well one evening and then waking up sick or something like that? Do you remember exactly kind of when it started? And most people with the flu can tell you within a day or two exactly when their illness started. Now, another clue that something is the flu is that it usually lasts for about 3 to 7 days. So if someone is saying, well, I got sick with the flu and then 4 months later, I started getting better, that's a very weird story. Usually it would be a lot quicker than that. So always think around 3 to 7 days. Of course, it could be a few extra days than that, especially when you're thinking about a symptom like the cough. But generally speaking, that's the time window. Then I really get into the symptoms themselves. I want to find out exactly what made them feel so sick. And there are two categories of symptoms. The first is respiratory symptoms. I want to know about respiratory symptoms. And secondly, I want to know about what I call constitutional symptoms. Constitutional symptoms. And this has nothing to do with the Constitution, but it has to do with the body, kind of thinking about symptoms that affect the entire body. So let me make a little bit of space on the canvas, and we'll first start out thinking about the respiratory side. So respiratory symptoms, let me draw out air coming into the body. Remember, air has two major paths into your body. It's going to come in through your nose, or it's going to come in through your mouth, right? And when it comes in, it's going to quickly join up. Remember, air in the nose is going to meet up with air in the mouth, and it's going to go down through the windpipe, or the trachea we call it, and it's going to branch off into the right and left lung. So this is my right lung over here, and on the other side we've got the left lung. And remember, the left lung is also going to be right next to the heart, so we've got to keep a little space for the heart. So these are the two lungs, and this is the air coming in. Now, if someone says that they have a stuffy nose, that's a really common one, right? They say they're congested, or sometimes they might say a runny nose, but any of these kinds of symptoms, you can think in your mind of this picture, and you can say, well, yep, this is right along the path that air is going to take on its way into the lungs. So this is part of the respiratory tract. Now, another symptom might be a sore throat, And here again, you can see that the air is actually going to be passing right through the throat on its way down into the lungs. And a really, really common symptom, you hear this all the time, is cough. And whenever people talk about cough, I just usually think about the lungs being involved there. So these symptoms, stuffy nose, sore throat, cough, you can think of this picture, and really you can visualize the air going through, and somehow these parts are being involved. Now, exactly what's happening is that the virus is, of course, coming in, right? It's being breathed in. That's how we take in the flu virus. And as it hits these different areas, the cells are getting damaged. And that's what we experience as a stuffy nose or a sore throat or a cough. It's really damaged cells that are being affected by the virus. Now, moving on to the other side, the constitutional symptoms. These are symptoms that I want you to think of as affecting the whole body. So this is the whole body. This is, let's say these are the arms and the legs. These are symptoms like fever. Now, if someone says they have fever, it's very hard to point to one exact part of the body that's affected, right? You might say, well, I feel feverish really all over. And if you're feeling feverish, this face would be very sad like that. So if you have symptoms like fevers, and with fevers oftentimes you get chills as well. I'm going to put that together. If you have fevers or chills, that would be a constitutional symptom. Another one would be something like body aches. You know, if you are in bed because your whole body is aching, you wouldn't point to any one place. You'd say, well, it's just kind of all over. And so that would be another constitutional symptom. Another one that jumps to mind is fatigue, kind of the same idea, where your whole body is affected here. So again, when someone tells me about flu, I'm thinking that they better have at least one of these respiratory symptoms and at least one of these constitutional symptoms. So I think of them in two categories, right? And I want at least one from each category. And they must have both if they're going to get me convinced that they have the flu. So scrolling up just a little bit, just to make sure we don't forget, it's got to be abrupt. It's got to happen over the course of 3 to 7 days. And they should have at least one respiratory symptom and at least one constitutional symptom. Now, this is good if I'm taking care of patients, or I'm thinking about a clinical setting like the hospital or the emergency room. But what about if you're doing research? Well, it turns out that the Centers for Disease Control, and they do a lot of research around influenza and flu, they have a definition that I want you to know about. Their definition, and you'll see this, is that the person has to have a sore throat or a cough, one or the other. I'll put a big or here. And they have to have fevers. So this is very similar to the definition I just gave you, but this is the definition they use when doing research and when actually presenting data. So it has to have these two things, right? Sore throat or a cough and fevers. And so this is the definition for influenza-like illness. Influenza-like illness. And the short way of saying all this is ILI, influenza-like illness. So this again is the definition from the Centers for Disease Control. So if you ever hear ILI, at least now you know what they're considering as being someone that has ILI. So this brings up kind of an interesting question, and that's why I kind of started out by splitting things up between the illness and the virus. I want to go over to the virus side and just keep in the back of your mind this idea of ILI. Now on the virus side, let me just kind of sketch out very quickly in this green color what the influenza virus looks like. I'm going to label this influenza over here. So this is my influenza virus, and this little virus has got some RNA on the inside of it. So it's got RNA in here. And I'm going to draw out the RNA just so you can see it. I'm going to use two different colors. So let's use like a purple color here. And one important thing about this RNA is that it's broken up into little pieces, the way I'm drawing it here. So it's got some purple chunks, and let's draw some yellow chunks of RNA as well. And this RNA, of course, is, as I said, genetic material, so it's going to be coding for proteins. So you've got some proteins, and let's say that you've got some proteins out here on the surface. And you could imagine that those yellow proteins come from one of those yellow RNA segments. And you've also got some purple proteins over here, some purple proteins. I'm going to draw out some purple proteins here for you. So let's say that the purple protein, we can call that H, and the yellow protein, we can call that N. So what you're getting here is that you're seeing a couple of the important parts of influenza virus that I just wanted you to start getting familiar with. The fact that it has RNA on the inside, that it's broken up into chunks, that it's got some surface proteins on the outside, and a couple of those important ones, we call them H and N for short. And I'll tell you more about them in a future video. So this is influenza virus. And now the question is, if you have someone, let's say I've got a friend or a family member who tells me that they had an abrupt illness that was 6 days, and they had fevers and a cough. Well, it sounds like, based on what I said, that this meets, of course, the CDC definition for influenza-like illness. And so if I tested them, let's say I actually, checked their nose with a little nose swab and did a test, you would expect that I would actually find influenza in there. And most of the time, I would actually find influenza there. But not always. And this is actually an important concept, that there are actually, believe it or not, some of these little copycat viruses. I'm going to draw a couple copycat viruses here for you. I'm going to write out two of them. There are actually more than two, but we're just going to talk about two of them. And I'm not going to draw them accurately. This is just kind of a visual representation, just to kind of show you what they are and write up their names. One is called rhinovirus. And you may be aware that rhino means nose, and actually rhinovirus loves to infect the nose, and that's actually why it's called rhinovirus. And another copycat virus, I'm going to draw it looking a little different, maybe a sideways looking thing, something like this. This guy, this is RSV. And the full name of RSV is respiratory, so it affects the lungs, syncytial virus, respiratory syncytial virus. And we'll talk about that another time as well. But the idea here, guys, is that these copycat viruses, and this is interesting, they can actually sometimes fool us into thinking that we're dealing with influenza. Because some of the symptoms you get with rhinovirus and that you get with RSV end up being pretty similar to the symptoms you get with the flu. And so as a result, we have to have some way of telling them apart. And that's why actually you may have heard of the term the cold. Let me actually bring this down and actually show you now the cold and the flu side by side and how to kind of distinguish between the two. So when you have, let's say, the flu, we said that usually you would have some respiratory symptoms, check, and you'd have some constitutional symptoms, check. But if you have the cold, kind of the common cold we call it, then you generally only have respiratory symptoms. You don't typically have fevers and chills and body aches and fatigue. You don't usually have that stuff with the cold. So that's kind of the easy and quick way to distinguish between the flu and the cold. And those are the questions I always ask, patients of mine. I say, well, did you have body aches or fatigue? And if the answers to all those kinds of questions are no, I'm thinking, aha, this person has the cold. But of course, this isn't exact, right? This isn't perfect. And that once in a while, people will actually fool you, and they will actually have one of these copycat viruses, the rhinovirus or RSV or adenovirus, there are many other ones, and they'll actually have influenza-like illness. They'll actually have sore throat and fevers and body aches. And so this is important to know, that every single time we clinically think someone has, flu illness, doesn't necessarily mean that they have the influenza virus.
Okay, whooping cough is caused by Bordetella pertussis, transmitted by droplets, has an incubation phase of up to 3 weeks. The catarrhal stage is characterized by a runny nose that lasts about 2 weeks. The paroxysmal stage results in bouts of coughing. The recovery phase is where you're susceptible to other infection. We use diphtheria toxin vaccine and antibiotic treatment for those that have the disease, but the vaccine is not going to provide lifelong immunity. A lot of outbreaks are due to lack of vaccination and lack of booster shots. And so you can see the rundown here. Note that the culture and diagnosis is through PCR, or we can also use ELISA in some cases. Respiratory syncytial virus is droplet contact. Preemies and individuals 6 months or younger are susceptible. The virulence factor is the formation of syncytia. The virus gets in there and it changes the membrane characteristics, causing the cells to fuse and to form multinucleate cells that are not fully functional. There's a passive antibody for high-risk children. Adults can get this as well. You can see here prevention through passive antibody, treatment through ribavirin. Again, it's viral, and the treatment modalities as a result are rather limited. Okay, we'll talk about the modes of transmission, virulence factors, and diagnostic techniques for our highlight disease TB, and discuss the problems associated with MDR-TB and XDR-TB, and talk about the features of other lower respiratory tract diseases, including healthcare-associated pneumonia. So here's a look at TB.
So I've drawn out for you a mother over here, a mom, and her son on the right. And it turns out that mom has tuberculosis. Let's assume that. And sometimes when you see tuberculosis written out the way I'm writing it out, you'll actually see them shorthanded, or kind of use the quick way of saying it with just 2 letters, which is TB. So let's say mom has TB. Now this is actually a diagnosis, right? This is a description of her illness. This is telling us what she actually has, what she's sick with. But we have to remember that tuberculosis is actually caused by an organism, right? It's actually caused by a bacteria, it turns out. And this bacteria has the name Myco, M-Y-C-O, bacterium, Mycobacterium tuberculosis. So this is actually a very easy one to remember because tuberculosis is right here in the name. Now I should point out, Mycobacterium tuberculosis is actually not the only cause of tuberculosis. Turns out there are a few other kind of related Mycobacterium, using this word myco, that also cause TB. But this one, the one I wrote out for you, this is definitely the most common around the world, and that's the one I'm going to focus on. And in fact, this myco, M-Y-C-O, this is actually Greek for the term fungus. And the reason that this is here actually kind of tells us a little bit about how this bacteria grows, because it grows really slowly like a fungus, and that's actually the reason that they use the term myco. But nevertheless, it is a bacteria, and so if we're going to put a little bracket around the diagnosis, I also want to put a little bracket around this part to kind of distinguish the two. So now you can see very clearly TB, the diagnosis, is caused by a bacteria. So now let's talk about how mom, who we said already is sick with TB, I'm going to actually just sketch out what her lungs might look like, assuming that the TB is in her lungs. This is actually the most common place we think of with TB, but not the only place. But let's say that she's got little red, I'm going to draw it in red, bacteria here in her lungs. causing her to be very, very sick with tuberculosis. She could spread it to her son. But what are the different ways that she might spread it? What are the most common ways? Well, let me sketch out a few possibilities, and we're going to go over whether these possibilities are very likely or unlikely to be a way for her to spread disease to her son. So let's say first, they're sharing this delicious pizza I'm drawing here. Let's say they're very into pizza and they, like to share food. And they both, chow down on this little pizza here. That's one way they might potentially, you might think of as a way to spread it. Maybe they're even sharing a drink. Maybe there's a drink here. And this drink, they're sharing again. You might also think about, what's going on in their house. Maybe they're opening and closing doors, and maybe they're touching doorknobs. There's another way, right? Maybe they're touching stuff in common. Maybe she says to him, hey, here, grab these keys. And she's been holding the keys all day, and then she gives him the keys and he holds the keys. There's another way, right? Maybe the TB can touch objects in the environment, like a doorknob or a key. And then there's the most obvious way you might be thinking. Maybe she's coughing. Maybe she has a loud cough. Maybe she's coughing all day, and some of these bacteria get in the air, right? So that's another way that you might imagine that the bacteria could spread from her to her son. So different ways, right? Now, of these ways, I'm going to actually label this one over here. Let's say this is through the air. Which are the most common ways to be really concerned about TB spreading? And I'm actually going to just put it in green so it really sticks out. The most common way is what we call person-to-person through the air. So in this case, the first person would be mom because she's sick, and it's going to go through the air down to her son. And these other ways, for example, food and drink, that's really not so common. That's really, really unlikely to be a way of spreading TB. And in fact, even this down here is really not likely either. So the idea of getting TB by sharing food and drink or touching objects in your environment like the keys or the doorknob or things like that, that's really not how TB spreads usually. Usually it's spread through the air. And one person, the sick person, is usually coughing a lot, and then the other person might breathe it in. So let me make a little bit of space on this canvas, and let's talk about what happens next. I'm going to draw one alveolus here, and then I'm going to copy it a few times just so you can see a few different possibilities in terms of what might happen. And these represent the son's alveoli. These are the son's alveoli. Of course, these are the tiny little air sacs at the very ends of the bronchial tree, right? So let me make a few copies of this. So there we go. We have 4 possibilities, right? Possibility 1, 2, 3, and 4. I'm basically going to go through different scenarios, different things that might happen when mom coughs. So maybe she coughs, and the first possibility could be that the bacteria, they just don't get far enough. They don't actually make it to the son, and he never ends up breathing them in. So if this was the case, there would be no bacteria in his alveoli. Of course, his lungs are nice and clean. Let me draw his lungs in. They look nice and clean with no bacteria, and he's feeling great, right? This is our son over here feeling really good, and we would say basically in this case, in scenario 1, he's healthy because the bacteria never even got to his lungs. All right, now scenario 2, let me actually erase a couple of these. Let's say that the cough actually was, very strong, and he was close by, and he ended up breathing some of these in through his nose or his mouth, and they went down into his lungs, right? So that's another possibility. Once the bacteria get there, let me actually draw them on this little alveoli. In possibility number 2, they might actually get picked up by little immune cells. So he has little cells that are patrolling the lungs, making sure they're nice and clean and healthy. And these little immune cells, I'm going to label them over here. These are macrophages. Macrophages. Actually, this literally means big eater because phage means to eat. And so these immune cells, they might kind of come by and gobble up these bacteria and take them in and destroy them. That's another possibility. So that would be possibility number 2. So here the bacteria are gone. Now let's play it out again. Let's say scenario 3, also you have a couple of bacteria in here, and just as before, you get a couple of immune cells that come by and they swallow up these little bacteria. These are the macrophages I'm drawing, swallowing up the bacteria. But let's say that unfortunately in scenario 3, now these macrophages for whatever reason, cannot destroy the bacteria. The bacteria are still living, and that's why I draw them here as little red dots. They're still living, still there. And now let me draw the fourth scenario, which is, again, let's say a couple of bacteria get in, and let's say that, the immune cells, again, they kind of, get alerted, and they kind of come by and pick up one of them. Maybe this immune cell is trying to go after this other one. Maybe he's really close by. But here the key difference is that these bacteria are actually multiplying. So I'm actually going to draw lots of them. These bacteria are multiplying, and they're filling up this space. So this space is filling up with little tiny red bacteria. So the key difference here is that these ones are multiplying. And we didn't really talk about the other scenarios having bacteria that are multiplying. But now that's the key new thing here. And in this scenario, we'd call it active because you're actually seeing the bacteria thriving. We call this active TB infection. Active TB infection. And that goes back to kind of what we would label the other scenarios, these ones. And these ones together, we actually call both of them latent TB infection. Latent TB infection. And the reason I'm putting them together is because it's very hard clinically to distinguish scenario 2 from scenario 3, because in both cases the immune system has previous experience with the TB bacteria. It's seen the TB bacteria, and in both cases you're not seeing lots and lots of bacteria dividing or multiplying. So we lump these together and call them both latent TB infection. The real key, and this is kind of the take home that I want to point out, is that there is a difference then between healthy, someone that's really never seen TB in their life before, latent, where you have seen TB previously, but you don't have any bacteria that are multiplying, and active TB infection, where you have lots and lots of TB bacteria that are multiplying. Let me make just a little bit more space then. I'm going to focus now on just this final one, this multiplying active TB infection situation. So if, let's say, our son in this case gets tuberculosis from mother or from mom, and let's say unfortunately he has an active TB infection, what are some clues to tell us that he has an active infection? So if I'm trying to figure out if somebody has TB, I always think about two key things. What are their symptoms? What are they sick with? That's the first thing. And then how long is it going on for? And I'm going to call that duration. And these two offer really, really helpful clues to figuring out if someone has TB. And with symptoms, I'm going to break it up into two categories. The first is constitutional. Constitutional. And this is constitutional symptoms. And this is kind of things that affect the whole body. The whole body. So I'm just going to put a little bracket on the entire body to remind us of that. And this could be things like, fevers or chills. You can't say, you can't really point to one part of your body and say, this is the part that's having fevers and chills. You'd say, well, just generally, I feel awful. This could be things like night sweats. If you wake up and your t-shirt is all wet, you might say, well, those are night sweats. Another example of a constitutional symptom is weight loss. In particular, when you're not trying to lose weight, especially because you're maybe not eating as much or you're vomiting or anything like that. And now the other category is lower respiratory tract. I'm going to say respiratory. I'm going to abridge it to just RESP tract. And this, if I want to draw it in, would basically be kind of the part I've drawn in blue here. So going down from your voice box all the way to the alveoli. So this would be your lower respiratory tract. And you can think about what sort of symptoms you might have there, right? So it could be things like coughing, right? That would be coming from the lungs. If you're coughing very hard, you might have some blood or some little streaks of red that are blood in your sputum. So it could be bloody sputum. That would be another one. And the sputum, of course, is just the mucus stuff that you kind of cough up. And a lot of people that are coughing this much, they might have trouble breathing or, chest pain, anything like that. So these are kind of just some examples of lower respiratory tract symptoms. And so I always think in my head, okay, are they having constitutional symptoms? If so, I put a check there. Are they having some lower respiratory tract symptoms? If so, I put a check there. And then how long is it going for? And usually with things like active TB infection, I'm thinking it's got to be usually more than 3 weeks. So more than 3 weeks. And this is again focusing on TB of the lungs or the pleura, which is the space around the lungs. Generally, the symptoms have gone on for a little while. So these then become very helpful clues to figuring out if someone actually has active TB infection.
So when you hear the term pneumonia, I think that most of us think about lung infection, but not much else besides that. And pneumonia really is a little bit more than just a lung infection, really in relation to where it is. So if we're looking at this image here, I want to focus on just the lungs that I've drawn out. So we know that we have a right and a left lung. And in our right lung, I'm just going to draw out some lobes here. We know that we've got 3 lobes in our right lung. So we have an upper, a middle, and a lower. And in our left, we've got 2. And we know that we have an airway, so a main airway. Now, don't focus on this yellow line yet. Just focus on our main airway. So we know that we breathe in air, and that air is going to travel down through these smaller branches, these branches that branch off. And at the end of our airway, we have these little grape-like sacs. So I'm just going to draw a couple just right here so we can see. And these little grape-like sacs are actually air sacs, and we call those alveoli. The alveoli is really important because that's where the gas exchange happens. This is where ultimately the oxygen is going to end up and where we'll pick up carbon dioxide to exhale out. So why is this important? Well, when we talk about pneumonia, the infection is actually in these air sacs. So what I'm doing is I'm drawing these sacs as if we could blow them up millions and millions of times because they're actually very, very tiny. We have millions of them everywhere at the end of our airways. So if we could blow them up, they'd look something like this. Now, right underneath it, I'm going to just keep drawing the kind of structure that we can expect that we'll see. So we have just air sacs I've drawn. Right underneath our air sacs, we have tiny blood vessels that run beneath them and all around them. And in between our air sacs, we just have some lung tissue. So I'll just make that this brown color, make some lines to represent our lung tissue. So when we say that a person has pneumonia, the pneumonia infection is actually inside of these air sacs. And this is where the pneumonia is. Now, anytime that there's an infection or injury in the body's response at that site is to cause inflammation. So that means that the tissue, that alveolar tissue, is going to inflame and it's going to leak fluid. Well, that fluid I'm making green and I'm filling up the alveoli with this green fluid to represent the infection. It's going to leak out infected fluid into this air sac. Now, why is this a problem? Well, remember, we're breathing in air, right? So let's come over here and make this blue. So let's say that here's my air. I'm just going to travel down some blue air and I'm breathing that down. I'm breathing that down. I'm breathing that down. And it's coming all the way down to our alveoli because this is where I want to drop off the oxygen so I can breathe and ultimately get the oxygen into my capillaries, right? Because that's what we need. The problem is that I kind of have this block. I have this infectious fluid that's blocking that absorption of oxygen, and it's going to block the exhalation of carbon dioxide as well. And that's a problem with pneumonia. It's taking up airspace. So as you can see, if this person had pneumonia, and let's go ahead and even draw it on our smaller grid. Let's shade in some green into our alveoli here. If this person had pneumonia, what will we expect to see in them? Well, we can see that we have our air sacs being occupied with this infectious material. So think about how that's going to affect their breathing. One of the things that we're going to see is dyspnea, which really is a fancy term for difficulty breathing. The problem that we're having really is shortness of breath. So I'll just put short of breath. And that's because looking at our image, we see that we're not able to have that gas exchange. We can't get that oxygen into our space because it's being blocked by something else. They're going to be experiencing chest pain as well. And we know that's secondary to the inflammation that's happening at the alveolar level. And we have pain receptors in our chest, so we're going to feel that. How about cough? Thinking about all that fluid in our air sacs, what do you think the body's going to try to do? It's definitely going to try to cough, right? That's the mechanism that our body has. It's going to try to cough to squeeze out and force out that fluid out of the airways to clear it so we have room to breathe. And we keep talking about infection. So with an infection, you can expect to see a fever. And that can be low grade or that can be high grade. So how does this happen? How do we get pneumonia infection? Well, there's really two ways. So it can be from organisms, right? Just that we get out in the community, or it can be from other ways that might not fit into that category. So for the first one, I want you to think about organisms. So I'm going to come over to the shoulder and I'm going to draw in a circle. That's going to represent my bacteria. And I'm going to draw in a little viral illustration to represent a virus. Bacteria and viruses are certainly the most common causes of pneumonia. The good thing is that we have vaccines to combat two of the biggest culprits, which would be our Streptococcus pneumoniae, that's our bacteria, and the flu virus. These are our big offenders that cause pneumonia infections. Now, when we pick up an organism like a bacteria or a virus, and we can also get funguses and mycoplasmas as well, we call this community acquired. And I'm going to write that here, community acquired pneumonia. And when I say pick up, I mean just in our everyday activities. Community, you're thinking about people. So think about work or school, or you're out doing leisure activities. Because you're surrounded by people, and if you picked up an organism from somebody that was ill, we would call that community-acquired pneumonia. Now, just as we have air, we know that the transmission of air into our lungs, if we get a bacteria that enters our airway, it's going to travel down and it's going to cause this infection. Now, we said we would talk about other ways. Something that falls under our other way would be ventilator-assisted or ventilator-acquired pneumonia. So I'm going to write that here, ventilator-acquired pneumonia. Make my D better, pneumonia. So someone's on a ventilator, we know that they're connected to a tube that's delivering oxygen to them. So let's come over here and actually just erase away my little air symbol that I made earlier. That way we can make room for our tube. And I'm just going to put it down to here. Now in this orange color, let's draw in this tube. So we know the tube is inserted through the mouth or through the nose, and then it's guided down into the airway. And it'll end about here. So this tube is going to be delivering oxygen to this patient. Well, on the outside, this tube is actually connected to a device. And so I'm going to write O2 here because we know that's doing the work of breathing for them. Well, what's the problem with this? We know that because it's a direct route from the outside to the inside, that things like bacteria, viruses, other harmful organisms can actually get inside of the tube, can grow, and cause a pneumonia infection. Another way that we can get pneumonia that doesn't quite fit under our community-acquired or ventilator-acquired would be aspiration. Now, aspiration means to breathe in. And in this case, we would be breathing in something into the lungs that shouldn't be there. So let's get rid of our tube so we can visualize aspiration. And I want you to really think about patients that are at greatest risk for this, like patients that have been experiencing vomiting, for instance. We could aspirate vomit into our lungs. Now, if you take a look at that yellow object that I said don't focus on earlier, take a look at that now and see how it's moving. This yellow object is our epiglottis. Our epiglottis really directs traffic. We know that we have one main tube, but this tube actually is split into two. One route's going to go to the stomach and one route's going to go to our lungs. So let me leave that open for a second and let's see the difference. So in blue here, this is going to be our direct route to our lungs. And then in green here, this would be our route to our stomach. It's all just keep that going down like it's going to our stomach. Well, in the event that our epiglottis is open, that means that something can get inside of our airway. So in this case, we talked about vomit. If somebody was vomiting and our epiglottis is open, we can actually aspirate the vomit into our lungs. And because our lungs are a sterile environment, anything that gets in there that's carrying bacteria is a danger to us because it can make us very sick. The same thing can happen with somebody that is eating and accidentally aspirates food into their lungs.
Here's a look at pneumonia. And here's the rundown of respiratory again: brown for bacteria, green for viral, and blue for fungal infections. Okay, I thank you for listening, and I will see you in the next podcast on infections of the urogenital tract, and that will finish out our material for the term. Thanks for listening.